Hello, everybody, and welcome to Friday. It's kind of a gray Friday here in Ottawa, but I hope it's been a great week for everybody. My name is Sandi Reggler, and I'm an epilepsy educator with Epilepsy Ottawa. I would like to welcome you all to our first webinar entitled EpLink Research Update on Improving Epilepsy Surgery Outcomes. We are very pleased to have Dr. Mary Pat McAndrews, who is the co-director of EpLink and a senior scientist at the Krembil Research Institute. She is also a professor of psychology at the University of Toronto and the director of the neuropsychology clinic at Toronto Western Hospital. She received her PhD in psychology from the University of Toronto and completed her postdoctoral work at the Montreal Neurological Institute. After Dr. McAndrews finishes her presentation, we will have some time to answer your questions. Please write your questions in the comment section and we will do our best to answer them. And I would also like to mention that since this is a public forum, if you would please keep your questions general in nature and do not divulge any personal information. And so we will welcome Dr. McAndrews. Hello, Mary Pat. How are you?
Hi, I'm great, Sandi. Thank you very much for
joining us.
Inviting me virtually into Ottawa.
Yes,
even though I can't actually travel there from Toronto right now. But
exactly.
But very pleased to be able to talk a little bit about our program of epilepsy research, EpLink. And I'm very happy to answer any questions that people might have. So I've really just prepared a little presentation to try and talk through some of the aspects of what we're trying to do within this program. And so I will now do, hopefully, share my screen so that you can see that presentation there. Okay. All right, so again, this is a little bit, as I've said, an update on the ideas behind why EpLink is actually trying to do some research to improve outcomes of epilepsy surgery. So hopefully I can give you some insight into that in the next 20 minutes. So first of all, if we talk about the history of epilepsy surgery, it might actually surprise people to know that the first epilepsy surgery was actually in 1884 that was carried out at the National Hospital in London. And then those early surgeries were really on individuals who had certain kinds of brain abnormalities, like after a traumatic experience or a brain abscess, who also had seizures as a function of that brain abnormality. By the 1930s, because of the guidance of EEG technology, they began operating on what they considered was the focus of the epilepsy, the abnormal tissue, the tissue that was acting abnormally, even if they couldn't see a structural lesion. And in the 60s, beginning of what we call stereotactic surgery, where we basically based brain areas on atlases that were derived. And then finally, the start of selective procedures in the 1980s. So a fairly long history reaching back to the 1880s. And there are a number of predictors that individual clinicians use to try and decide whether or not surgery is a good idea for individuals, or to enable them to best predict what's the likelihood of a success in terms of individuals. So for example, whether or not they will become seizure-free. And there are a number of different variables that have been looked at. And some of them are up here on the screen, things like the age of onset when you began having seizures, the age at surgery, how frequent were your seizures before surgery, whether or not you actually had convulsions as part of your surgical picture, and whether or not there was an MRI abnormality that was able to be seen. And there are actually many different centers that are trying to use different processes to understand better which of these are the best set of predictors for an individual patient. And so the 5-year outcome data for temporal lobe epilepsy surgery, which is the most common epilepsy surgery in adults, is that about 70% of individuals will experience seizure freedom. They may still be remaining on some medications, but the medications will be much reduced from when they went into epilepsy surgery. But we already know that the outcomes are poorer for people who don't have an abnormality in the brain that we can identify on MRI, and indeed for other epilepsies that arise in other parts of the brain, other focal epilepsies. Seizures are starting at a particular focus, but not in the temporal lobe. Those outcomes are generally somewhat worse as well. What happens is, even in the best of cases, some individuals may return for additional workups. An epileptic focus could be established now that couldn't be treated before or needs additional surgery. Does that mean that we did a bad job at the outset in using our predictors, or was there some kind of abnormality genetic-wise that we missed initially and didn't know that, in fact, you weren't a great candidate for epilepsy surgery? And then finally, other individuals are now denied surgery because of the current tools and predictors that we have don't give us enough information to be able to proceed, to be able to do that, because either we can't really identify where that focus is, or because we're really concerned that taking out that focus might cost an individual significant function in terms of speech, perception, motor function, or memory. And finally, there's the occasional unexpected cognitive or affective mood disturbance post-surgery that we just didn't know how to predict in the first place. So although success is reasonably good, there still are a number of opportunities for improvement, one should say. So I just want to very briefly touch on what we what's the standard workup, as we might say, for determining whether or not a candidate currently is a candidate for epilepsy surgery. And there are really three key points to look for. The first and foremost is really, can we detect and identify where that seizure focus is, which generally means coming into an epilepsy monitoring unit where we attempt to capture seizures, like in this individual, with recordings of the EEG 24/7 and video monitoring, where we're reducing medication in order to see whether we can capture what are individuals' typical seizures. And here's a kind of cartoon EEG readout where you can see that some of the brain waves over the course of time look quite stable, and then there are periodic blips in these particular areas, and those are areas of concern that might actually be identifying that epileptic focus. The second key point for determining surgical candidacy is whether or not we can see something on an MRI. And the MRI has improved dramatically even in the course of how long I've been doing epilepsy work for the past 20 years or so. And so here we can just show you two kinds of MRI pictures, and the circles identify what commonly is looked at in terms of the signature kinds of pathology that we see on an MRI. In this case, something in what's called the hippocampus or the mesial temporal lobe, where we see some abnormality, some atrophy, some dead tissue, basically. And in this case down here, where we see this other kind of sign up here in the frontal lobe, which is usually a signature of something called a focal cortical dysplasia. And these two kinds of abnormalities, we know from many years of research, are highly epileptogenic. They are the types of lesions that actually are very highly associated with epilepsy or with seizures. They can't be well controlled. And then the final key point that we look for is neuropsychology. And essentially, we test a whole bunch of different functions of the brain. We look at IQ, attention, memory, language, etc. And really, that's because different functions of the brain depend on kind of different real estate and networks within the brain. So we can kind of make a determination, oh, are we seeing something that points to pathology in that one area of brain? So for example, in temporal lobe epilepsy, again, the most common type of epilepsy that comes to seizure surgery, we are focusing on memory because those regions in that hippocampus are very important for memory. And we also kind of know that there's a difference between the left side of the brain and the right side of the brain in terms of memory. And that is that the left side of the brain in most people is really responsible for remembering verbal material like words. And the right side, that right temporal lobe, is most responsible for remembering faces or other kinds of visual material. So we might look to see, oh, does this individual who has left temporal lobe epilepsy, are they showing that they're weaker in remembering words than they are in remembering faces? So if that's true, then that pattern of abnormality does fit or align with those other indicators. So if an individual then says, the EEG says you have left temporal lobe seizures, the MRI says you have a left temporal lobe abnormality, and our neuropsychology says, hey, your left temporal lobe isn't working as well as it should for memory, but the rest of the memory system is working just fine. Under those circumstances, we can say, this is actually a very good candidate for epilepsy surgery, all other things being equal. In cases where those three things don't align or we don't get enough information out of one of our standard modalities, there are a number of other kinds of techniques that can be used and that are used. For example, we might look at something called a PET or a SPECT scan. And here, these are really scans that are telling us something about the blood flow in the brain. And we can look to see, is there an area of your brain where the blood flow seems to be reduced? And you can see in this picture here, a little bit of a reduction. It should be symmetrical or the same on both sides. Another technology that we can use is called a magnetoencephalography. This is another big kind of tube that you go in, but basically it's sensitive to different brain signals than the EEG. It reads out the same kinds of brain signals, but it's sensitive to different ones than the EEG. So it might be able to pick up something that the EEG missed or wasn't clear about. And then finally on top, there's also additional diagnostic tests we can use. We use something called functional MRI. And this is a way basically of seeing where in your brain different kinds of regions are responsible for those areas of function, like language, for example. So here is just showing you a single individual with a lot of different brain cuts here, with the bright spots actually showing areas of the brain where there's more activity when the person is using a language task than when they're not. Finally, if we can't tell from all of what are non-invasive techniques, that is putting electrodes on the scalp of the brain, all of our other imaging techniques, we might actually have to go for something called intracranial EEG, where electrodes are now deposited directly on the brain surface in order to get clarity. And the older techniques usually use something called grids or strips, where you see this kind of plastic with little electrode sensors directly on the surface of the brain. And the newer techniques are called stereotaxic EEG, where we can actually use MRI to plan where to put these electrode probes that come directly into the brain. So we can sample more deeply in those structures in the brain. So what's the decision to go ahead with surgery? Well, we have to feel that we're confident about that focus. We know where the seizures are starting from, and we know we have a good sense of the extent of that tissue that needs to be removed, that zone of epileptogenic tissue, so that we can remove that and have a good outcome in terms of seizure surgery. And we also want to be confident with our neuropsychology techniques and our functional MRI that removing that part of the brain isn't going to come at a significant cost in terms of functions like language or memory, because that's not a good trade-off. So the decision to go ahead is often, being able to be confident in those two things and using some of our other predictors. But I just want to give you an idea of why we still need to do better. I gave you that idea because I gave you kind of general statistics saying, well, in 30% we don't have that greatest outcome. But sometimes it's helpful to see for an individual case. So this is a kind of case actually from our own service, although some aspects have been changed. But a young man who wanted to pursue a career as a pharmacist. On his MRI, we showed no abnormality. Okay, so that's already a little bit of a warning sign. In his neuropsychology, he had good verbal skills and normal memory. So that tells us that there's really no signal showing that some territory of the brain is functionally compromised. So we knew there's no structural compromise, no functional compromise. When we went to the EMU, his scalp recording showed that seizures were coming from both the left and the right temporal lobes. So now we really had to do that intracranial or invasive EEG. But on that EEG, we actually saw 11 seizures, and they mainly started in the left hippocampus, that mesial structure in the temporal lobe, but they did quickly involve the right side. Nonetheless, given all the information, the plan was to offer this individual what we call a standard anterior temporal lobe resection, including these internal structures of amygdala and hippocampus. And here is an MRI, not of his, but a kind of standard post-operative MRI, where you can see that here now there's been a part of the brain removed in that temporal lobe. And you can also see this is a cut through the brain, a horizontal cut, and this is a sagittal cut. You can see that piece of tissue missing. So this is a standard resection that was done, but unfortunately, it didn't actually result in a positive outcome in any of the things that we want to look for. So in this case, he had only 2 months of seizure freedom. Now his seizures are somewhat less frequent, but more intense. We brought him back to the EMU, and we saw that now he had seizures coming from the other side. His mood declined, his cognitive function, his memory declined, and now there are very few options to offer this gentleman. Certainly no additional surgery can be done because we've already taken out the memory structures on the left side. We can't do the same on the right side, or else there will be a huge cost in terms of memory. So we clearly need to have learned more in order to get a better outcome. And that's where the background for this particular project of EpLink comes in. So what is EpLink? It's a larger scale than what I'm going to be talking about today, which is just surgery. So I'll just give you a little bit of basic background. It's a multidisciplinary epilepsy research program that's being funded by the Ontario Brain Institute. And our mission is really to reduce seizures and improve quality of life for people with epilepsy through our research. The way we do this is to engage clinicians and researchers to work very collaboratively to collect what we call standardized clinical data from patients that will then allow us to answer some of those critical research questions, we hope. And there's also part of this, the program that doesn't involve individual patients directly, but is looking at animal models for other purposes like drug development. Just to highlight who the people are, there's actually a multidisciplinary team that's in the leadership. Mac Burnham, who's a professor of pharmacology at the University of Toronto, myself, who's in the neuropsychology at University Health Network, and Sharon Whiting, who's a pediatric neurologist at CHIO. We also have a vibrant community advisory committee that's made up of individuals with lived experience, as well as some individuals from community agencies. And essentially, it's a network of about 25 clinicians and researchers that work across 6 different clinical and academic institutions. So what we're really trying to do is harness all of the available data that we can in a very standardized fashion so that we'll be able to answer some questions in a way that we wouldn't have been able to before. Essentially what we want to do, it's not the case that I don't want to pretend that research hasn't been going on in each of these institutions for a very long period of time. Of course it has. But the idea here is that it's been done in silos before. So really what we hope to do is to break down those silos so that we can collect the data that I'll be telling you about in a minute. We'll be able to put it all in a standard space, which is called brain code, that can also talk to other kinds of databases, like the health administrative databases, so that eventually the hope is that we will have a very large cohort of patients to be able to answer some of these questions and have better outcomes. We'll use fancy new technology like machine learning to be able to see the things that we can't see with our individual hypothesis-driven eyes, where we say, oh, I have a hammer, everything's a nail, I'm just going to look for that. Now we're going to be able to have many different sources of data, and sometimes that means that the individual researcher might not be able to see patterns that are really critical for cure. And the other important idea of this is open data. And so the idea behind Brain Code and the Ontario Brain Institute is that after a certain period of time, these data, of course not identified by individuals, but the data themselves will be able to be released to the broader public of researchers who might be able to answer those questions that we have left lagging behind. So again, our aim is to be able to do 2 things. Localize that focus better and make sure we can characterize both the network that is causing seizures, so we can remove that network, and the networks that are responsible for cognition, so that we can make sure that we maintain those over time. And we have a number of different, very specific objectives that we're looking at here to be able to use all of these data. Again, better localize that focus, identify those brain regions that are critical for language and memory, characterize patterns of seizure spread, understand better how these functional networks may be altered by seizures, and ideally identify those predictors of outcomes so that we'll be able to know that, for example, in a case of our 21-year-old gentleman, that we needed either to gather more information to say this particular surgery isn't for you or no surgery is for you under these circumstances. Okay. So this is just a little kind of cartoon diagram to show what I've told you in words, all of these various different data sources. We're collecting, we're gathering individuals who are presenting to district or regional epilepsy centers. We're collecting a whole bunch of information. In some patients, the really clear ones where all those 3 things line up perfectly, they may go to surgery directly, and then we'll study them again with the same measures 1 year after surgery. For individuals who don't have those clear predictors lining up, we'll do some additional assessments using newer technologies that then hopefully will be able to lead them either to a surgical path or to being able to say, no, no surgery is really recommended for you. And what we're hoping to do is to actually collect more individuals on whom the pathway isn't straightforward, because we feel we're doing a decent enough job with them, and it's these other individuals where those 3 clinical indicators don't line up that we're not really getting the job done well enough. So we're really trying to harness more of our efforts towards identifying them. So I've told you already what some of these data sources are. Here are our standard data sources. We collect a lot of information about individuals' seizure types, what their drugs they're on, when they started having seizures. We collect all of their EEGs while they're on that epilepsy monitoring unit. We do a whole host of neuropsychological tests so we understand better what their profiles are in terms of memory and cognition. We do MRIs, we do functional MRIs, and then we look at the outcomes after surgery. So those are the standard things that we've already been doing, but we can even answer, or we can even address some novel questions even with those standard things, like using new ways of analyzing our EEGs to be able to do a better job at identifying that network, or using our novel functional neuroimaging techniques to be able to identify those cognitive networks. So even the techniques that we're already doing in our standard practice, because we'll be doing it with more individuals, because we'll be doing it with more clinicians and scientists weighing in on the different analysis techniques, we should be able to make more traction on those questions. But when we have to go further, we will be going further with those kinds of techniques like the intracranial EEGs and using fancy new statistics to be able to look at those in a different way than we've done before. We'll be using much more high-powered MRI that can show us much more detail than the standard MRIs that we currently have. We'll be trying to do more work with this MEG. We'll be doing more work with our fMRI with very novel, fancy kinds of analysis techniques that we haven't been able to use before, because we've needed this new, we've needed larger sources of data and a different kind of analysis that we can't use regularly. And we'll also be looking at DNA. Blood is being drawn from all of the individuals, so that if in the end of the day, the reason we failed this individual was because we didn't realize there was a genetic abnormality that made it very unlikely that they would actually be able to be cured by epilepsy surgery, we'll be able to understand that as well. Okay. What do we hope to come immediately out of this? And by immediate, I kind of mean the 5-year term where we get to see what the results are of this. We'll be able to combine old and new tools to improve our ability to localize where that seizure focus is and increase our positive outcomes. We can adopt any new techniques that we're doing now, or that we're going to be able to do out of this research program. We'll be able to then retrofit, take back into our standard clinical workflow. So if we've devised a new way of looking at these EEG signals, now that can become our standard of practice. And so we've got new tools to be able to work with. We're hoping that in the long run, fewer patients will need to undergo that invasive monitoring where we stick electrodes directly into the brain, because that's one additional surgery. And if some of our techniques are going to be able to tell us exactly where that focus is without sticking those electrodes in, we're happier. And in fact, it's even better to be able to manage to get more patients through our epilepsy monitoring units. Right now, we're actually serving a very small slice of the individuals who could actually benefit from surgery are being able to access these epilepsy monitoring units. So if we can do our workups more efficiently and effectively, then more patients can benefit from it. And what are our long-term impacts? Well, obviously, we want to be able to improve the clinical care of patients and families, improve that seizure control, and improve quality of life if we've both gotten a handle on seizures and reduced postoperative morbidity. We want to be able to generate these large data sets that is going to be more comprehensive than anything that's currently available. And if we are able to do that and share that with other epilepsy centers, we might get more traction on a cure. And why is the government interested in funding this? Well, obviously, if we manage to do a better job, there's immense reduction in cost to the healthcare payer, the government. Long-term medical costs, improved seizure control means people can go back to work and have better postoperative consequences and less morbidity. And our new techniques actually may make some of the very expensive evaluations that we do now no longer necessary. So I hope I've given you a kind of snapshot view of the program and why it's needed, what we're doing, and what we hope to be able to come out of in 5 and 10 years with this. And I would be happy, because we're just kind of at the 2-year phase right now, I'd be more than happy to return in a couple of years to give you some actual results. So having said that, I thank you very much for your attention, and I'm happy to answer any questions you may have.
Thank you very much. That was most informative. I found it very, very resourceful. We do have a few questions. Our first question is from Joanne. What is the significance of the age of onset in terms of surgery?
Sorry, you dropped out. The significance of, that's okay.
Of the age of onset.
Oh, age
in
of
terms
onset.
of surgery.
Yeah. So it's interesting that the expectation is that if you're having, the longer we leave an epilepsy focus, the more likely it is to recruit more and more brain tissue, essentially. So that's part of the reason why people have made a push towards earlier surgery, right? Mm-hmm. So I would say about 10 years ago, when we looked at our data, we found that the average amount of time that an individual went from diagnosis to surgery was 20 years. So that's 20 years in which your brain is actually doing bad things and remodeling in very bad ways. And so really the guidelines now are that based on pharmacotherapy, that if you've failed 2 of the standard frontline anti-epileptic drugs, then you really should be evaluated for surgery because it's very unlikely that adding an additional drug, at least of the ones that we currently have available to us, is going to help you out. So we would really like to see people earlier on in the course so that they don't have that opportunity to kind of set up a bad system, basically.
Perfect. Thank you. There's another question here from David. In your example with the 21-year-old male, he had the surgery and then after 2 months the seizures returned. How common is it for the seizures to return, and do the results differ from adult to child? And what is the process of after the surgery? If it's determined unsuccessful, what is the process afterwards?
Sure. No, that's great. All great questions. So when I quoted that kind of 70%, again, that was for the best possible case where all of those indicators lined up and generally in the temporal lobes. So that's what we have the most experience with. So you can imagine that that leaves 30% of people without those good outcomes. So I would say maybe 30 to 40% is a rough estimate of when things go wrong. Remember, in that young man's case, actually, there weren't a lot of really good indicators for him. We did have to go, he didn't have the MRI sign, his neuropsychology was fine, and his scalp EEG said it was on both sides of the head. Now, I'm not going to give you because I don't know off the top of my head the statistics for people who then go onto that intracranial investigation where we said, well, we think it's good enough because 11 of them all started on one side. So we have a pretty good confidence that if we get that, that's really the generator. And it spreads fast to the other side, but let's knock out the main driver and hopefully that will manage to tamp down the other area. So I can't tell you if it's like 50% of the time that works and 50% it doesn't, because unfortunately, honestly, I don't know the answer to that. I will say that we agonize over those kinds of cases in our seizure conference when we have the surgeon and the neurologist and all of us sitting around trying to figure out, well, what should we do here? Because just saying you're not a candidate for surgery means, for resective surgery, means that you then have few options available to you. again, there's not another drug that's going to help you. So there is a potential of diet therapy, which isn't really used a lot in the adult world, much more in the kid world, and for stimulation surgery. So there are a couple of different types of devices that you can use. One is called a vagus nerve stimulator, and that's pretty common in the pediatric population, much more so than in the adult population. And then there's something called deep brain stimulation, where either a probe with a stimulator is put directly into the brain. It's kind of like the deep brain stimulation that's done in Parkinson's disease, but it's done for in a different location. Or not yet available in Canada, we have something called responsive stimulation. So these are really clever little microchips, basically, that are put on the surface inside the brain, and they can detect a seizure and then try and disrupt it by a burst of stimulation. So neither of those are really curative procedures at this point in time. They're more, I won't say experimental, they're certainly being used clinically, but we see, they can reduce the amount of seizures that people are having, but they rarely result in a flat out cure, unlike surgery. And when the question about childhood versus adult, I gave you data for adults. I believe for focal seizures in children, it's not a different story. But children, there are many other kinds of childhood epilepsies that have much more profound disruption in the brain. And so very few of those will actually go to a surgical approach.
Okay, great. There's another question from Nikki. If research is successful and a technique demonstrates improved outcomes, what is the process of it going from research to practice, and what is the timeline?
No, great questions. Part of it depends if anything requires development of a drug or a device, that's all in Health Canada's hands. so the timeline gets to be very long, as you might imagine.
Yes.
As I said, even that responsive neurostimulation, which has been available, I think, for about 10 years now in the US, it's called NeuroPace, is the trade name there, is not available in Canada. And the manufacturers supposedly have said, look, it's not worth our while. Canada's too small a market, and it will take too long to jump through the regulatory hoops. So that's the stumbling block there. Other things, not so much. So I talked a little bit about doing something called functional MRI to map out where in the brain the language networks are. We have only been doing that clinically, I would say, for probably the past 8 to 10 years. And in fact, some centers don't do it as standard of care yet because they don't have the necessary expertise there. That went from a research question directly into, through 8 years or so, but into clinical practice. And so that's not an invasive kind of technique. So it's much easier to have that kind of cycle. And I think all of us are very much hoping that if we can discover something through this kind of machine learning approach about data we already have, that's I hate to use the term, but a no-brainer, basically. Because, if everybody's got it and all you need is, a decent computer to put it together, the discovery part takes a lot more, but the implementation part probably shouldn't take very much. And again, that's one of the reasons for us to be able to put our own data available to the world so that, maybe we're not going to actually discover it, but maybe, the classic, 16-year-old kid in his parents' basement is going to sort it.
Of course. I'm sure there's lots of those hiding out right now.
Exactly.
Lots of time to do it too.
Exactly.
There's another question. So with so much focus on, there seems to be the surgical outcome for temporal lobe is so much higher. Will there be more focus on, say, surgery in the frontal lobe and ways to improve that?
Sure, great question, and my bad. I should have said that. In fact, as I told you, we're more interested in capturing data from individuals we don't think we do a good job with already. And so we're actually, this particular phase of EpLink, we're looking both at temporal and frontal lobe.
Okay.
So both groups of patients are coming to us as well. Obviously, you can have seizures coming out of the parietal lobe here or occipital lobe. We decided as a group we would focus on those two because those are the two. The frontal lobe is the second most common one.
Right.
And usually frontal lobe surgeries, I would say almost always involve that intracranial implantation. Unless there's like a very, very clear focus on the MRI and, you know, they feel, okay, we know exactly where this is. But certainly those are ones because the frontal lobes are big territories in your brain.
Of course.
And the scalp EEG, you know, is going to be good at picking up things, but it won't isolate exactly where. And so the idea of the intracranial is so that you can narrow down. You don't want to take it. Surgeons often say, go big or go home. And by that, they mean we actually want to take it. We know we want to take out enough tissue that you're not going to come back with seizures again.
Right.
But we don't want to take out so much that we're actually, you know, maybe compromising function. Right. So,
absolutely.
And that's definitely the you know, how often does the people come back after surgery? I'd forgotten to answer that piece of the question. But if we feel like, hey, we can take you back in, and just like that gentleman, if what we found, oh my gosh, the seizures are still coming from the left temporal lobe, but there's a little bit of tissue that's left, that remains there that we didn't take out. And that's actually what we think is the bad actor. So we can go back, we can take that out, and hopefully that will be the end of the story. And in some cases, that actually does turn out to be the case. That it just means more has to be taken relative to what was done before. And that's probably even more common in frontal lobe surgeries.
Okay, perfect. Another question, this is from Carolina, would you start AED withdrawal anytime after surgery?
So I'm not a medical doctor, so I'm very lucky because I don't have to actually answer that question, but I will tell you what a medical doctor might tell you, or at least what I understand our epilepsy neurologist to say. So it's been the standard ever since I started training that people are very reluctant to do anything for the first year. And outside of the hearing of a surgeon, I hope no neurosurgeons are on here, I often say, look, it's like a big hammer was just taken to your head, so let's let things settle out, okay? And so that's usually the strategy, is to not do anything for a year. There are exceptional circumstances. I can think of a few occasions where, for example, somebody was worried because of the particular medication they were on, they wanted to start a family, et cetera. So you know, that's a dialogue to have with your neurologist, but 1 year is usually before they don't want to do anything. Okay. I believe that the current kind of strategy, advice people give is, again, the reduction of medication is the aim. Drug-free is not necessarily the aim. Because it may be that you have, especially again for a long duration of seizures, you know, again, the way I kind of think of it is your brain's learned how to do this now. It's actually very good at causing seizures. And even if we've taken out the main generator and we think we've got everything we need to calm things down, it's still possible that you're going to need a little bit of that medication to keep things in abeyance. So that, I think, is more the standard now, is to say, look, you should look for hope. The hope is for seizure freedom, not necessarily drug freedom.
Okay, perfect. We've got somebody joining us who wants to say hi. It's Lorraine Hogg, would like to say hi.
Hello back.
And we've got one more question. How resilient is the brain when it comes to recovery?
Oh, that's such a wonderful question. And really at the heart of it for me. I'll just tell you that part of my research is very much looking at that resilience, especially in terms of things like memory. And that's why we want to understand the networks. When I started this business, you know, we focused on one little part of the brain. We said, okay, this medial temporal lobe, this hippocampus, that's all I need to care about. And, you know, as it evolves over time, you realize, hey, it doesn't actually do anything in isolation. In fact, what's really important is what it's talking to and what the rest of the brain is capable of doing as well. And so we've started on a program of research where we're using this functional MRI to be able to understand how those networks are organized before surgery, and then to be able to say, what is the type of network that's most resilient to surgery? Because remember, we actually do have these memory and language tests before you go to surgery and then 8 months to a year after. So we can look at a whole bunch of individuals who've gone through the surgery and say, okay, someone was a winner in that game because they actually didn't, you know, they maintained their memory, and some people lost more in terms of the memory. And so what about those networks tells us what's important for that resilience? And we've started to kind of hone in on 1 or 2 different ideas. Because we were able to see in some individuals, when we brought them back to the MRI machine and scanned them after surgery, that we saw some connections on the side that wasn't operated showing an increase. And the more the increase in those connections, the better the memory. So if we can figure out what the secret sauce is in terms of making those connections grow, then maybe we can figure out a treatment or therapy to enable that for everyone, so that you don't just have to win the lottery to be able to grow those connections, but we can actually give you a better ticket.
Of course. Perfect. Well, I think that is all the questions we have. I would like to thank you immensely for joining us today. It has been very resourceful and very informational. Thank you so much. And I appreciate you coming on and taking your time to join us.
Yeah, it was wonderful. And if anybody's interested, eplink.ca, have a look at it, because again, I told you only about a small slice of the whole program. We have a diet therapy, we have drug trials, etc. So there are other things that you might be interested in to have a look at what's going on in the province for epilepsy research.
Perfect. Perfect. And I'd like to thank everyone for joining us. And I hope you can all join us next time for our next webinar.
Great. Cheers to Ottawa.
Thanks.
Okay, bye.